Thanks to the organizers. Thank you, Dr. Kumardi. Thank you, Dr. Varun, for this opportunity. So the topic I'm speaking on is on, can I share my slide? It's showing that I cannot start screen share, so if I could be allowed to. Yeah. So it's immune checkpoint inhibitors. How are they making way in the first line setting of gastric cancers, GE junction, and esophageal adenocarcinoma? So I hope my slides are visible over there.
Yes, sir.
Yeah. So as we know that this is a complex organ. The esophagus, the GE junction, and its eventually, formation into the gastric organ. So these organs definitely have a different biology. There is heterogeneity, although adenocarcinoma in the lower 1/3 of GE junction can happen, as well as stomach adenocarcinomas, but then they are different actually. Molecularly, they are different, and the causative agents are different. We see that most of the GE junction adenocarcinomas are related to refluxes, obesity, as over metabolic syndrome, one may call. The distal gastric carcinomas are different. They are caused by H. pylori. They're caused by alcohol intake. They're caused by smoking. So they are different actually, and molecularly as well. The HER2/neu enrichment ERBB2 is more so in the GE junction region. The squamous part, of course, is something like the molecular profile is quite similar to the head and neck. So that's a different category altogether. So when we talk about basically the incidences, we see that the gastric carcinomas are nearly 60,000 plus being diagnosed almost every year. And likewise, esophageal cancer is quite a similar figure over there. What is the stark, or rather, it is a sad reality that almost a similar number of patients we are losing to this particular disease every year, quite a similar number. So that's the sad part. Well, the risk factor, as I just mentioned, for the gastric is different, and the gastroesophageal junction is different, and that's what is important. GERD is predominating in the proximal GE junction, but H. pylori is more so for the gastric, and that's important. Obesity for the cardia part is there, but then for alcohol is there for the non-cardia part. So there is a difference over there. And we all know the TNM, since we are discussing the metastatic over here. So basically, we will be talking about the M1 status in this particular talk. This is the AJCC 8 prognostic staging gastric cancer pathological classification. So what we see is this is a poor disease subset with a high mortality rate, and there is critical unmet need for new treatments that can improve upon the standard of care chemotherapy, which has been used for several years now. Current options are largely limited to doublet or triplet chemotherapy regimens. So when we talk about the guidelines, what they say is like, if it's a locally advanced unresectable or a recurrent or a metastatic disease, then we are talking about how is the performance status of the patient, and if it's less than 2, then we actually look towards biomarkers. We all are doing this. HER2/neu has been there as the biomarkers which we asked for in metastatic setting. PDL1 is now coming up, and MSI is also an important one, a tissue agnostic marker. So MSI, these 3 are the important ones basically. And then we actually go ahead discussing how to go about chemoradiation or systemic therapy or best supportive care. So this is important. We just discussed these biomarkers, how they are getting important. HER2/neu was there, the it's been almost more than a decade for TOGA trial, and we are using it quite regularly. We do appreciate that there is a lot of heterogeneity involved with this particular marker. The prevalence is almost to 15 to 20% across across the various regions, and prognostically, it's basically more for the GE junction area, the proximal stomach, which is actually having this particular marker, the intestinal subtype. The PDL1 is something what we are realizing now, that this is around 24 to 38% than previously reported. It might be slightly lower. Prognostic value, well, it indicates that they are associated with the inferior overall survival, and predictive value is irrespective of the PDL1 status, although higher overall response rates were observed in PDL1 expressors. For the MSI, of course, they are in a range of 4 to 22%, and they are associated with reduced risk of mortality, lymph node metastasis, and tumor invasion. However, association with improved prognosis remains ambiguous in light of conflicting data. And they definitely have a predictive value in terms of immuno-oncology drug response. So they are now established tumor agnostic markers. And now talking about both the tumor intrinsic factors and the extrinsic factors, which actually led to the need of this particular scores. So you have tumor PDL1, but then this combined positive score was from the idea that the tumor milieu is important and the infiltrating cells are important. So PDL1 staining tumor cells along with the lymphocyte macrophages, and this formula is there, which is upon the tumor total viable tumor cells. This is a percentage. So introduction to this particular drug that we are talking, nivolumab, and this is basically a PDL1 blockade inhibitor, and we can see that it actually releases the brake of the pro-inflammatory cells, the T cells, the Tregs, which actually start hitting the tumor, and eventually cell death, the tumor cell death takes place. So we're talking about Checkmate 649 today, and this was the trial, one of the global trials basically, and a phase 3 study for first-line treatment of advanced upper GI cancers. And here the enrollment was unresectable metastatic GE junction, gastric, esophageal adenocarcinoma. They all were HER2 negative and PS01. So the stratification was PDL1 expression greater than 1% or less than 1%, and ECOG was good ECOG. They were distributed as stratification factor was also, since the chemotherapy arms were, the chemotherapy was left to the physician, so Capox or Folfox. So if it was Capox, then the nivolumab dose was 360 mg once in 3 weeks. If it was 2 weekly Folfox, then it was dosed at 240 mg. Nearly a 1:1 randomization. The standard arm of chemotherapy, Capox and Folfox was there in its usual interval protocols. The dual primary endpoints was overall survival and PFS, and it was in PDL1 CPS of more than 5, which was there. And secondary endpoints were there, which included checking of the survival, overall survival in CPS 1 greater than 1, overall survival in CPS greater than 10, PFS in PDL1 CPS more than 10, 1, or all randomized. Then overall response rate was looked at, and then there were exploratory endpoints, and that was safety and quality of life parameters. So the statistical testing was basically the PFS and the overall survival. It was like if you are actually obtaining positive results for a CPS of greater than 5, then actually you go ahead and check for overall survival. Statistically, formal statistical analysis was done if for overall survival PDL1 CPS greater than 5, and then overall survival for all randomized patient was done. Well, likewise, overall survival for PDL1 for CPS more than 5 was achieved. Then overall survival for PD-L1 CPS more than 1 was done, and then again for all randomized. So basically, all primary and hierarchically tested secondary endpoints for ORBITA and FOLFOX or CAPOX were met at the 12-month follow-up. You look at the baseline characteristics, which were well balanced between both the treatment groups. So the gastroesophageal junction, as we can see, the gastric cancer was predominating over there, almost 70% in both the arms. And PD-L1 expression, well, it was more than 1% in a quarter, basically. So what we see is a lot of liver disease, liver metastatic disease, and signet ring cell carcinoma is also there, 15% of the patients. And then you have MSI high, again, included over there, 4%, nearly 4% and 3% in both the arms respectively. FOLFOX or CAPOX, as we can see, almost equivalent distribution of these two chemotherapy regimens in both the arms were there. So nivolumab and FOLFOX or CAPOX demonstrated overall survival benefit irrespective of PD-L1 status. And this was there in the all randomized. There was a 2-year overall survival rate of 28% versus 19%. When we look at the CPS greater than 5, greater than or equal to 5, then it was 2-year overall survival was 31% versus 19%. Well, when we talk about the PFS benefit, it was maintained with the nivolumab and FOLFOX or CAPOX with longer follow-up irrespective of PD-L1 status. Talking about the overall response rate, the other secondary endpoint which remained higher and duration of response was longer with nivolumab and FOLFOX or CAPOX versus the chemotherapy arm. Talking about overall response rates in MSI high, where you do expect that this would actually have good response rates and result in better survival. Here again, longer median overall survival and higher overall response rates was observed in all randomized patients with this particular subset of when nivolumab was combined with chemotherapy over there. Consistent overall survival improvement was seen across all the pre-specified group, whether the primary tumor location was gastric carcinoma, GE junction, or esophageal adenocarcinoma. So it's pretty consistent in the addition of this particular drug. Also, if you see the PD-L1 expression is, both the less than 1% and greater than 1% getting the benefit of this drug. The MSI status, of course, as we can see, is getting the benefit. Liver metastasis is getting the benefit. Also, signet ring carcinoma is the hazard ratio is less than 1. So basically, all pre-specified in subgroups were actually benefiting with the addition of this drug. And for PD-L1 CPS less than 1 and less than 5, if we see that the hazard ratio was actually quite in favor in both the groups, it was less than 1 as compared to, numerically it was the figures were higher in the combination arm versus chemotherapy arm. And the combination did demonstrate a higher overall response rate and longer duration of response across CPS cutoff. And overall response rates was high with the combination or CAPOX versus FOLFOX or CAPOX, and duration of response was longer. So basically, this is what 42% of all patients randomized to the combination versus chemotherapy received subsequent treatment. And we can see that a lot of patients received taxanes over there. Ramucirumab was also there in certain patients. So the most subsequent subgroup, the most subsequent therapy was actually systemic anti-cancer therapy. And no new safety signals were observed when this combination was studied. So there weren't any new safety signals, although numerically there were more numerically more side effects as compared to the chemotherapy arm. So immunological side effects, if we see grade 3 or 4 with the addition of this drug to chemotherapy, not going in above 5%. So most of them 1 or 2% grade 3-4 side effects, the immunological ones. So regarding the quality of life issues, it did not result in additional bother from treatment side effects as per this score sheet, FACT GA GP5. So the quality of life was maintained, and you can see that it did not result in deterioration of quality of life from baseline for patients with CPS more than 5 as per GCS, EQ5D, and EQ-VAS assessment scores. So addition of immunotherapy to FOLFOX or CAPOX did not result in deterioration of quality of life from baseline. And the least squares mean difference between the treatment groups favor the nivolumab plus FOLFOX or CAPOX versus the chemotherapy alone. So there was a decrease in risk of symptom deterioration when in the combination, irrespective of PD-L1 CPS status. And again, lower risk of deterioration with the combination, as we can see in this. So overall, basically, the risk of quality of life issues were deteriorating less with the combination as compared to the chemotherapy arm. So currently, the approval in our country is basically for the combination is for basically advanced or metastatic gastric cancers, GE junction and esophageal adenocarcinoma. And you can choose basically the dosing 240 mg or 360 mg based on the chemotherapy partner that you're choosing. And the maximum treatment duration is 24 months basically for this. And to summarize that nivolumab is the first PD-1 inhibitor to demonstrate superior overall survival and PFS in combination with chemotherapy versus chemotherapy alone in previously untreated advanced gastric carcinoma, GE junction, and esophageal adenocarcinoma patients. Superior overall survival benefit was found more than 28% amongst all the randomized patients, and the high response rate, 58% patients receiving the combination responded, included 11% complete responders irrespective of the PD-L1 CPS status, and therefore that makes it a point to actually consider whatever the PD-L1 score is to consider the combination. So no new safety signals were observed, and the addition of this drug to chemotherapy maintained the quality of life basically and decreased risk of symptom deterioration and no additional bother from side effects. Longer follow-up and further support, longer follow-up of the combination to further support its use as a new standard first-line treatment in patients with advanced gastric carcinoma, GE junction, and esophageal adenocarcinoma. So, thank you.
So, thank you, sir. Congratulations. This was a very lucid presentation, and you have covered all the salient points. So, just sir, I want to ask one question with your permission. Yeah, so as you have already shown that combination with FOLFOX or CAPOX, this nivolumab is already recommended for GE junction and gastric cancer. But if we see NCCN guideline, they specifically quote that if CPS is more than equal to 5, then we should add these drugs. And if less than 5, then according to NCCN, it is category 2B recommendation. So what your take on that? Like if we see in detail these trial results, there is no difference according to hazard ratio or according to other results. There is no difference on the basis of CPS value as far as I got like this trial. So what's your take? Whether we can use nivolumab in combination with FOLFOX in first line GE junction, even if CPS have been done or not, whether there is need for CPS to be done, or if less than 5, then what we should do?
So basically, since it's approved in our country for this particular above anything above irrespective of PD-L1 or above 1%. So we can actually consider not doing it, because there are patients who are still benefiting in PD-L1 less than CPS less than 5%. So what we see is numerically these survival figures are definitely more. Number two is that the quality of life issues were better, symptom deterioration was lesser. So yes, for above CPS 5, the MCBS ESMO scoring is 4 and above, 4 rather. But of course, for less than that, it makes a point to consider these particular factors if in case we want to use.
Yes, yes.
And so, also that the tail of curve is important. So sometimes we do not get the perfect idea with the median figures. So the tail of the curve in immunotherapy is important. And that some percentage of these patients still continue to get benefit with its use.
Yes, sir. So I think so, like same as you have already mentioned, that already we have added this drug to FOLFOX in first time G junction for maybe 3-4 patients, and we have seen good results. And we have already doing in maintenance also. So that also important, because after completion of chemotherapy, maybe most of the patient tolerate it by 8 to 12 cycles, by around 10, then tolerance issue is there. After that, if we can continue these drugs, IO agents, then PFS increases and patient quality of life improves. So with this, we will go on to next session.